to update you on the pathogenesis of a commonly seen disorder, that is minimal change disease. So as we all know, minimal change disease is one of the most common causes of idiopathic nephrotic syndrome in children, with an estimated incidence of 1 to 16 cases per 100,000 children. It accounts for almost 70 to 90% of childhood nephrotic syndrome older than 1 year, and it accounts for 10 to 15% of adults who present with nephrotic syndrome. The hallmark of minimal change diseases damage to the glomerular filtration barrier, leading to increased renal membrane permeability and highly selective albuminuria. The glomerular filtration barrier, as you all know, has an inner layer which is the fenestrated endothelium, the middle layer which is the glomerular basement membrane, and the outer layer which is composed of a specialized epithelial cell which is the podocyte. So the podocyte is the crux of the glomerular filtration barrier, which has a large central body with multiple foot processes which rest on the glomerular basement membrane. And the apical membrane of the podocyte consists of certain sialoglycoproteins such as podocalixin, podoendin, which make the surface negatively charged, and this plays an important role in the charge selectivity of the proteinuria. And the multiple foot processes which arise from the body of podocytes from the different cell bodies interdigitate, and the space between the adjacent foot processes is connected by a thin membrane structure that is 40 nanometer wide, which is commonly called a slit diaphragm. And the slit diaphragm has multiple proteins, as we all know, with nephrin, synaptopodin, podoplanin, cadherin, podosin, ezrin, podocalixin, and all these proteins have some role to play in the pathogenesis of minimal change disease. Another important component of the glomerular filtration barrier is the glomerular basement membrane, which has multiple main components, that is laminin, type 4 collagen, nidogen 1 and 2, and agrin. The agrin is very important because it again contributes to the negative charge of the glomerular basement membrane. So to summarize, the charge selectivity of the glomerular filtration barrier is because of the apical and luminal membrane of slit diaphragms and podocyte, which is coated with podocalixin, the outer layers of glomerular basement membrane which has heparan sulfate proteoglycans which is negatively charged, and the endothelial glycocalyx and its fenestration. So all these three components contribute to the charge selectivity. So it all started in 1974 when Mr. Robert J. Shalhoub tried to find out what is happening in lipid nephrosis, as minimal change disease was then known. So in 1974 he proposed it to be a disorder of T cell function, and he proposed that there is an increased glomerular permeability due to an unknown circulating permeability factor which is released by the dysfunctional T cells. So he coined 4 supportive evidences for his postulates. That is, he noted that patients who had minimal change disease went into remission following a measles infection. Minimal change disease was commonly associated then with Hodgkin's disease, which is a known T cell disorder, and there was a very good response to agents which interfere with the T cell immunity, mainly the corticosteroids and cyclophosphamide, and the humoral component deposition, as evidenced by immunoglobulin deposition and complement deposition, was almost absent in these glomeruli of patients with minimal change disease. So as of now, the pathogenesis, what sets into motion the disease process, is not exactly known. There is multifactorial, as recently discussed in the previous session. Toxins also play a role in stimulating the pathogenesis. And there are 2 main components which play a role in the pathogenesis. That is, it does not happen in all individuals. It happens only in certain genetically predisposed individuals, and there is some amount of immune system dysregulation which leads to multiple downstream events leading to minimal change disease. So in 2011, Shimada et al. In his classical paper presented, he proposed a 2-hit theory for the pathogenesis of minimal change disease. The first hit was a direct stimulation of podocytes due to some toxin or infection, either viral or bacterial infection or some allergens, which sends into motion some T cell stimulation leading to multiple T cell cytokines release. That is most probably the interleukin 13. And the second hit is the immune response is not regulated, and there leads to overactivation of the immune system, leading to persistent proteinuria, which causes the minimal change disease. So this is the crux of the pathogenesis of minimal change disease. So there are a group of triggers which set into motion a group of multiple pathways which are mediated by multiple mediators, which lead to multiple mechanisms at the end organ level. That can involve the podocytes, that can involve the charge selective barrier, and also it involves the endothelial cell. So either infections or some toxins can cause some amount of dysregulation in genetically predisposed individual, leading to multiple mediators release, thereby leading to the end organ effects. This is the crux of MCD pathogenesis. So, as we all know, T regulatory cells are very important in maintaining the immune homeostasis and the tolerance to self-antigens. So, increasingly T cell regulation, that is T dysfunction, became T regulatory cell dysfunction, which leads to impaired autoregulation, leading to increased CD80 expression, which leads to persistence of the transient proteinuria which normally occurs, leading on to minimal change disease. This is the vicious cycle which sets in minimal change disease. So, the most common T regulatory cells which play a central role in the immune response is the FOXP3 positive Treg cells. There are two types, mainly the thymic Treg cells and also the peripheral Treg cells. The importance of regulatory T cells in the pathogenesis of minimal change disease is already well known and described in form of an IPEX syndrome, where there is dysfunctional mutations of the FOXP3 gene causing the classical syndrome of immune dysregulation, polyendocrinopathy, enteropathy, and it is also X-linked. So, based on the recent data, this is a Chinese group which proposed an injury loop model for the pathogenesis of minimal change disease. So, there they described 4 phases in the pathogenesis of minimal change disease. The first phase being an imbalance between the T regulatory cell and the T effector cells. The second phase is the podocyte injury phase. The third phase is the injury loop phase, and the fourth phase being the restoration of the homeostasis phase. So, the initial trigger is unknown. There are multiple postulates, and there are multiple precedents like infections, allergens, toxins, and drugs which can set into motion the multiple downstream pathways. So, in genetically predisposed individuals, there is a numerical or functional imbalance between the FOXP3 positive Treg cells and the T effector cells. So, in response to an undefined antigenic stimulus, it leads to overproduction of cytokines which reach the podocytes through filtration. And these cytokines have a direct effect on the podocytes, causing damage to the podocytes and increase the glomerular permeability. And the podocyte then start acting like antigen presenting cells, and they start, if the T regulatory cell mediated T regulatory cell mediated regulatory mechanisms fail, they start expressing and shedding the CD80, and the soluble CD80 diffuse back into the bloodstream and bind to CD28 on the T effector cells, and thereby leading to continuous activation of the immune system and synthesis of cytokines in a podocyte injury loop. So, this occurs in a vicious cycle and leads to dramatic onset of proteinuria in patients with minimal change disease. Suppose the Treg cells were normal, or if the Treg cells were able to control the T effector cells through secretion of suppressive cytokines, then the immune balance is restored and the injury loop is terminated. So, multiple studies have also documented the association between minimal change disease and atopy and allergies, as well as the MCD has been driven classically by Th2 responses, and of the multiple Th2 cytokines, the interleukin 13 overexpression has been shown to induce food process in multiple experimental animals as well as in human studies. No wonder MCD is also called as renal asthma. And what I would like to stress on this at this point of time is no single cytokine has been documented to be, no single cytokine has been documented to be pathogenic. There have been multiple cytokines including interleukin 13, interleukin 8 and interleukin 4 which have been studied in both animal models as well as in human studies. So, recently, till a long time it was thought to be of only a T cell disorder, but recently there is multiple evidence coming up for the involvement of B cells in the pathogenesis of MCD. And this was heralded by the effectiveness of rituximab in creating remission in patients with steroid sensitive and steroid dependent nephrotic syndromes. So, multiple lines of evidence are there which can implicate the involvement of B cells in these in the pathogenesis of MCD. Though the total there is no immunoglobulin deposition in the biopsies, the total IgG as well as multiple IgG subclasses display alterations in the nephrotic patients, and there have been multiple case reports and series of minimal change disease which have been observed in patients with monoclonal light chain diseases implicating altered immunoglobulins in the pathogenesis of MCD, and in multiple studies there have also documented or demonstrated the increased plasma soluble CD23, which is a classical parameter of B cell activation. And similarly, there are multiple evidences against B cells. The classically thought teaching that there is no immunoglobulin deposition on renal biopsy in patients with MCD, which goes against the involvement of B cells. And rituximab, though it is a B cell influencer, it can have a direct effect on the podocytes as it directly binds to the SMPDL3B And this antiproteinuric effect of rituximab can be documented and can be explained without a effect on the B cells also. This is well explained because once the B cells reconstitute after the effect of rituximab infusion is over, some patients still maintain prolonged remission after a single course of rituximab. So the B cells are postulated to play a role in pathogenesis by having some crosstalk with the T cells and promoting certain T cell responses, and B cells may also have a role in releasing autoantibodies against the podocyte proteins. So the second point is much highlighted in the recent paper which was published in JASN by Watts et al., who have demonstrated in a group of patients, they had demonstrated that there is circulating anti-nephrin antibodies in almost 29% of patients with biopsy-proven MCD. So the authors had an indirect ELISA assay against the nephrin, and the threshold for positivity was chosen to be 187 units per ml, and it included patients from his own cohort as well as the Neptune cohort. So as seen in this visual abstract, almost 29% of patients with biopsy-proven MCD had documented anti-nephrin antibodies. And out of these 18 patients who were documented to have anti-nephrin antibodies, 11 patients who went into remission subsequently demonstrated that their anti-nephrin antibodies had reduced or had become completely absent. So coming to the classical pathological finding that MCD does not have any immunoglobulin deposition on IF, it is actually only partially true according to the authors. And some patients in their cohort, they went and looked back, they actually found that these patients with MCD had actually subtle IgG staining, which is not as impressive as membranous nephropathy changes. And almost all the time the IgGs were co-localized with nephrin, and the classical description what they describe of this the deposition is punctate IgG staining on the glomerulus. All these patients were documented to have positive serum antinephrin antibodies. So how do these antinephrin antibodies lead to proteinuria? They might they postulate that they directly bind to nephrin, which changes its localization in the slit diaphragm and leading on to proteinuria. And another concern in this postulate is whether these antibodies definitely play a causative role or whether they just are a paraphenomenon is still not clear. So similarly, there are multiple other autoantibodies against podocyte antigens which were studied by multiple groups. This is another group which had studied UCHL1 antibodies, that is against the ubiquitin carboxy terminal hydrolase L1, which is expressed inside the podocyte. And this was studied by Jamin et al., and they documented that anti-UCHL antibodies were found in almost 50% of patients with steroid-sensitive nephrotic syndrome in relapse. And interestingly, these antibodies were not increased in patients with adult with MCD, thereby creating a concern whether childhood nephrotic syndrome, as childhood MCD and adult MCD have different pathogenesis. So the UCHL antigen which is expressed in the podocyte is released by the injured podocyte during some trigger like viral infections, which leads to an autoantibody production and in situ formation of antigen-antibody complexes with IgG, and the podocyte detaches leading on to proteinuria. This is the postulate for the proteinuria. And another group also studied another antibody which is an annexin A2 antibody, which was detected in almost 17.8% of their patient cohort. So multiple studies have come up, and whether it is a form of autoimmune podocytopathy is yet to be known. As I told earlier, this does not happen in all patients. There are certain genetically predisposed individuals who develop MCD, and in contrast to FSGS, Mendelian mutations are rarely described, and it is mostly polygenic inheritance. There are certain genes which are studied, that is the IL-4, IL-13 gene polymorphisms as well as STAT6 gene polymorphisms are all associated with MCD. As I told you, there are changes in glomerular filtration barrier. It is not only the podocyte which are affected, there are changes in glomerular filtration barrier which are also demonstrated in patients with MCD. And as I told you earlier, the sialic acid is important contributor for the polyionic component of the glomerular filtration barrier, and it is documented that glomerular hyposilation associated with podocyte effacement has been implicated in MCD. This is an exploratory study by Husing et al., who assessed renal biopsies of 27 patients with different glomerular disease, and he documented that almost glomerular hyposilation in 26% of patients with all proteinuria glomerular disease, more so in patients with minimal change disease. So this glomerular hyposylation also has a therapeutic implication where whether there is a role for therapy other than steroids in such patients is to be studied. That is N-acetylmanosamine, which is a sialic acid precursor, may be having a role in ameliorating proteinuria in patients who have documented glomerular hyposylation. And the third component being the endothelial glycocalyx, it also has a thick network of glycosaminoglycans and proteoglycans which prevent the passage of negatively charged albumin. And the role of this has been studied and demonstrated by increase in circulating syndican-1 in many patients with MCD. And multiple mediators have been studied in the past and also now, including hemopexin, which exists mostly in the inactive form, whereas the active form of hemopexin has serine protease properties which can affect the podocyte function and structure. Lennon et al. Demonstrated that there is a nephrin-dependent reorganization of the cytoskeleton when there is hemopexin in the active form in the plasma. This is a study which looked into the involvement of hemopexin, and they found that hemopexin levels are increased in patients with nephrotic syndrome, that minimal change disease in relapse when compared to these patients in remission. Classically studied molecule was CD80, which is a transmembrane protein expressed on the antigen presenting cells and NK cells. Previous groups have reported that CD80 expression in podocytes increased during relapse, and it was not present during remission or in other causes of MCD. And urinary CD80 was also proposed to be a marker for MCD in relapse. But what is the status now? Multiple studies have questioned the specificity of CD80 in patients with MCD. Multiple studies have documented that CD80 was expressed in multiple other glomerular diseases also. And this is one study which studied the role of urinary CD80 as a diagnostic marker, and they found that increased urinary CD80 expression was present in all patients with active kidney disease rather than the etiology. It does not correlate with the etiology. And next is the angiopoietin-like 4, which is a highly expressed glycoprotein in the liver and adipose tissue. Podocyte-specific angiopoietin-like 4 expression in rats induced albuminuria in the experimental models. And the pathogenic angiopoietin-like 4 was hyposylated angiopoietin-like 4, which bound to the glomerular basement membrane, neutralizing its negative charge and also causing injury to the glomerular endothelial cells. So again, multiple studies have studied the usage of angiopoietin-like 4 in minimal change disease. And serum and urinary excretion of angiopoietin-like 4 were not specific for MCD, and it might correlate with proteinuria, but it is not specific for MCD in recent studies. Some studies have come up which include CMIP, which is a CMAF inducing protein, which is an 86 kilodalton protein with unclear function and scarcely detected in the normal human kidney. And the CMAP interferes with podocyte signaling, leading to cytoskeletal disorganization and food processes effacement. This CMAP is very crucial in certain subset of patients with MCD. That is, patients with MCD or FSGS who develop MCD or patients who develop MCD or FSGS on VEGF tyrosine kinase inhibitors like sorafenib and sunitinib have documented to have overexpression of CMIP, and the CMIP is coming up in a big way as a factor in the pathogenesis of MCD. That the pathogenesis of CMIP is that it interacts with FIN, which is an SRC kinase, and it modifies the nephrosin phosphorylation, affects the cytoskeletal architecture, and causes proteinuria. Coming to the latest papers which have been coming up, it studies mainly the involvement of a family of transcription factors like zinc fingers and homeoboxes, that is ZHX1, 2, and 3, which regulates the expression of key podocyte genes, and they are usually seen on the podocyte membrane, and they translocate to the nucleus, and based on the expression of multiple ZHX proteins, it has been shown that nuclear ZX3 alone has been associated with FSGS, nuclear ZSH1 expression has been associated with MCD, and this is one paper which has come up in 2023 November, which links ZHX transcription factors to angiopoietin-like 4 expression. So in ZHX hypomorph state, it makes the podocyte inherently susceptible to the mild cytokine storms resulting from a common cold. And in such podocyte, the ZHX proteins are redistributed away from the normal transmembrane partners like aminopeptide A towards the alternate binding partners like interleukin 4 receptor alpha. And during the disease relapse, it is already documented to show high plasma soluble interleukin 4 receptor alpha, and this leads to nuclear translocation of ZSH1, which induces severe upregulation of angiopoietin-like 4, leading to incomplete silation and hyposilation related injury to the glomerulus. So coming to the take-home messages, as of now, minimal change disease is still very much a T-cell disorder, and the T-cell dysregulation has been the crux of the MCD pathogenesis till now, as explained in the injury loop model. The autoimmune etiology with B cells playing a role and autoantibodies like antinephrin and anti-UCHL1 antibodies need further elaboration. And this is not a disease affecting the podocytes alone. This affects all the components of glomerular filtration barrier. And no single cytokine has been pathogenic. CMIP is coming up in a new way with a certain subset of MCD patients. And the latest advance being at the molecular level, the involvement of zinc fingers and homeobox proteins along with the hyposilation injury to the glomerulus, which needs to be further elaborated. So we are yet to solve the complete puzzle in MCD, and further studies will be definitely required to understand the pathogenesis of MCD as of now. Thank you.